So
Okay.
I want to begin by saying that not every person requires a therapist and a prescriber. However, TCN does offer both of these services as well as interventional services. And so while each of these services are beneficial on their own, the greatest effect really can be seen when the services are worked in conjunction with each other. So when a client's treatment suggests the need for more than one service, it becomes very necessary to collaborate. The collaboration will also ensure the client feels supported, bridges a potential gap between medication and therapy providers, and it really does ensure the best possible outcome for the client.
Next, we want to go over some of the different degrees that you can hold to be a therapist and a prescriber. When you're on one side or the other, it can be a little confusing to know where the others are coming from. Listed therapist examples, LPCs are not on here, but they should be. So LPCs, MSWs, licensed mental health counselors, PsyDs, licensed clinical social workers, masters in education, masters of arts, masters of science, lots of different things you therapists can be. And then as prescribers, nurse practitioners, if you're a psychiatric nurse practitioner specifically, you're a PMHNP. So that's psychiatric mental health nurse practitioner. The BC at the end means board certified. And NPs, unlike PAs, when they go to NP school, you pick a path. So you decide to be psych, you decide to be women's health, you decide to be peds, whatever it is. Some of the paths are more general than others, like family medicine, but you do pick a specialty when you go into NP school versus PAs go in and they are trained in everything, similar to how physicians are trained. And then when they graduate, they get to decide where they want to work. So a lot of our PAs have a special certification called ACAQ Psych, and that means that they took a special test after they graduated PA school to prove that they have this above and beyond knowledge of psychiatry. And so then we have physicians, these are MDs or DOs, and they go to medical school for 4 years. And then they do a psychiatry residency, usually 3 or 4 years. And then sometimes they do a fellowship if they want to do some sort of extra specialized training, like child adolescent psych can be a fellowship, and that's usually another year or two tacked on after residency.
So as you can see from the previous slide, as therapists, we have very different educational backgrounds than do the prescribers. We may know a lot about the potential of how medications help relieve some of the client's symptoms. However, it's not in our scope of practice to advise clients around how medication works and what should be prescribed. In the same light, prescribers have some training in therapeutic techniques. However, in this model, their scope is medication related. They may provide some supportive therapy during their med visits, but the heavy lifting for both therapy and medication is left to the individual expert providers. Because of our diverse backgrounds, collaboration is the key to successful teamwork. The more we can learn from one another, the more effectively and efficiently we can treat our clients.
So next we're going to talk about improved patient trust through our shared goals. So it's important to consider that part of collaboration is making sure that as the prescriber and the therapist, we're on the same page. And it's really nice that throughout TCN, we have clinics that have both therapy and med management in-house and interventional as well. But it's really nice when we are all able to collaborate. We can really wrap around the patient. And though in this presentation, we're just talking about therapists and prescribers, it's interesting too in our company to think about interventional services as well. I have patients that I see for Spravato treatments, but they're treated by a different NP in my practice, and then they see a therapist through us. So really wrapping around, making sure everybody's on the same page can help the patient feel really supported, really well cared for and looked after. It can also humanize treatment a bit to feel like, okay, I'm not just the third patient on Maureen's schedule today, and she's going to see me for 30 minutes, and it starts at this time, ends at this time, and that's it. But really to come to the appointment and say, hey, I spoke with your therapist, we talked about XYZ, and that made me think of this medication you're on, and maybe we could tweak this. And it's helpful because then the patient says, okay, I'm not just a chart ID, I'm not just patient number whatever to you. I really am somebody that you care about and somebody that you're looking after and someone that you're really wanting to wrap around and give very high quality care too.
So keep in mind, collaboration does not always mean putting yet another appointment into our calendars. Communication can be done by using tools we already have. We can do it via Teams. We can also use Valence Secure Messaging. Both of these methods are HIPAA compliant. And in some cases, if collaboration does require more intense conversation, we can have a separate meeting. But most collaborations do not take a long time. However, they do have a long-lasting effect on the treatment for clients. They should be done frequently, which will also negate the fact for a longer meeting. If you are having regular collaboration, you're going to be updated more regularly with the client.
This next piece is coordinating treatment plans. So it's helpful to collaborate for lots of reasons. One being we are trying to decrease treatment fragmentation.
Oh, I'm not sure what happened to Maureen.
Hello, everybody. I apologize. I'm in the office in the DMV and our internet went down. So I was sharing a slide. I'm wondering if Karen, if you're able to share them, or should I share them on slide 10 maybe?
Yeah, let me find the slides.
While you're finding that, I'll jump back into what I was saying. I don't know at what point I froze, but talking about coordinating treatment plans. So, and Jack or Karen, maybe you all can restart the recording if possible. Talking about coordinating treatment plans, I was saying that from a prescriber view, if someone comes to me for the first time and they have ADHD and anxiety, I would think to myself, well, some ADHD medications, particularly stimulants, can make anxiety worse. So from a medication management standpoint, I'm going to look at that patient and say, okay, I'd really like to treat your anxiety first, because if I can get that under control, we can then talk about an ADHD med. But if we start with the ADHD med, it might make the anxiety worse. We have other problems. We have bigger problems. it just might not be the way to go. However, if the therapist has the opposite view, for example, if they think the ADHD is much more significantly impairing the patient's daily life than the anxiety is, they might say, well, let's focus on that first, which both sides have merit, right? But if we get together and talk about those things and make sure the patient understands that we're on the same page, we can avoid pulling the patient in two different directions and making them feel like we are working against each other rather than working with each other. And by working with each other, and as Karen said earlier, playing to our strengths, we can really help move treatment forward versus taking one step forward in therapy, but then a step back with meds, and a step forward with meds, but then a step back in therapy. That's not what we want to do. So it can be really helpful to make sure that the patient doesn't feel as though they have to choose between listening to the therapist or listening to the prescriber. They can feel confident in both of us, because when you do have patients that are feeling pulled in two different directions, they can often lose confidence in either the therapist or the prescriber or both. They can feel like, one person knows what they're talking about, but the other person doesn't. How can I trust them to care for me? Those kinds of things. Whereas if we simply collaborate, we can get on the same page and then, decide how we want to proceed, and can make the patient feel a lot more supported.
Okay, so I wanted to include a case example just to kind of illustrate what we've been talking about. So I am going to read this slide. So example 1, Maureen, a psychiatric nurse practitioner, is treating Sarah, a 34-year-old woman diagnosed with major depressive disorder. Despite being on medication, Sarah's symptoms such as low energy, hopelessness, and trouble sleeping persist. Maureen recognizes that medication alone may not be enough and refers Sarah to Karen, a therapist who has experience in addressing emotional and behavioral changes. Through collaboration, Maureen and Karen communicate regularly about Sarah's progress. Karen helps Sarah address potential roots of negative thought patterns, relationship struggles, and patterns of behavior with Maureen, while Maureen adjusts her medication to better support her mood regulation. This combined approach allows Sarah to gain coping strategies through therapy while ensuring the psychiatric aspects of her condition are effectively managed, leading to significant improvement in her overall well-being. So this example is very common in our practice. Due to certain possible constraints of appointment times and caseloads, it's difficult to treat complex symptomology with one modality. This can be seen in the opposite manner as well. So at times, a clinician might notice that the sheer amount of energy a client is spending just managing their symptoms, as far as low energy, sleep inconsistencies, low mood, may be a barrier to their own ability to progress in therapy. So eliciting the help of a prescriber to evaluate the potential for medications to help them with those symptoms can result in the client having additional energy to learn and implement new strategies to improve all-around functioning.
So when we think about understanding the patient's history, it's important to consider that therapists, meet with patients more often than prescribers usually do. But then also, patients have more time with therapists generally, at least in the DMV, they usually have an hour, whereas for med management, you'd have 20 or 30 minutes. So when you're talking to the therapist, when the patient is, they have more time to share, and they often feel more comfortable digging into those deeper topics, those deeper feelings. Trauma is a really good example. It can be easier to open up to one person than in a long session, rather than say, oh, hey, by the way, in a shorter session where you'd also be talking about meds. So it really is another good example of playing to our strengths, understanding that the therapist, that is part of their job, to get those details out and to really dig deeper with the patient. Prescribers don't always have the time. And as Karen mentioned earlier, while we have some training in psychotherapy, we are not experts like you all are. We're experts on the meds, but you all are experts on the psychotherapy piece. So it is really nice that you have the time. And patients often do end up sharing a lot more with you all. And that is very valuable. But I would say from the prescriber side, I really appreciate when a therapist is able to share with me those details that the patient uncovers, because I don't always have the time to talk to them. They don't always have the time to talk to me about that. They might want to talk about a medication side effect or something like that during our sessions. But when the therapist can even send me a quick Teams message or stop me in the hallway and say, hey, I saw well, not in the hallway talking about a patient, pull me into their office and say, hey, I just saw so-and-so and this is what we talked about. I just wanted you to know we uncovered this deeper thing. We talked about this relationship in their life, whatever it is. And that can be very helpful for us, and it can help inform our medication choices as well.
So it's important to note that collaboration is ongoing. Therapy appointments are usually more frequent than med appointments, and therefore potentially a therapist will gather overall more information regarding the client than the prescriber will. So client tends to limit the sharing of information that a prescriber follow-up visits to medication effects and maybe some larger details if there's some major event going on. Because of this difference, it's very important to collaborate on a consistent basis and share vital information. While clients are working toward exploring root causes of their identified issues in therapy, it remains important that they are still sleeping well, able to maintain a brighter mood, and have energy to continue progressing toward their treatment goals.
Okay, now I'm going to read you a case example. This is 2 parts. So part 1, James is a 28-year-old man. He's been struggling with severe anxiety and occasional disorganized thinking. His symptoms have worsened over the past few months, affecting his ability to work and maintain relationships. His primary care provider refers him to Maureen, a psychiatric nurse practitioner, who starts him on medication to address the anxiety and potential underlying mood disorder. However, Maureen is concerned about James's disorganized thinking, which may suggest a more serious condition. And then next slide, if you're able. Okay, thank you.
Sorry about that.
You're good. Maureen reaches out to Karen, a therapist with experience in working with patients who may have psychotic or mood-related disorders. Karen conducts a thorough evaluation of James's cognitive and emotional functioning, documenting signs of thought disturbance and emotional dysregulation. 2 professionals collaborate, with Karen providing detailed insight into James's behaviors and emotional responses, while Maureen adjusts the medication to address the complex symptoms. Together, they identified that James's symptoms align with a possible early onset of bipolar disorder with psychotic features. While the combined efforts of both the prescriber and the therapist, James receives a comprehensive treatment plan that includes medication management and targeted therapeutic support, ultimately leading to more stability and improved functioning. I really like this example for a couple of reasons, but the number one reason being that the sooner we can identify most psychiatric conditions, I can't think of one that this wouldn't apply to, the sooner we can uncover what the true issue is, and the sooner we can get treatment going, the better outcomes the patient has. So specifically for psychotic disorders, we know that if you have many, many psychotic episodes, even manic episodes, they can unfortunately cause damage to the brain. And so you want to get somebody out of a manic episode as quickly as you can, which usually happens with medication. And then same thing with any sort of psychotic features. You don't want the person experiencing those because it can cause damage over time. And again, a lot of it is damage over time. It's not severe acute damage, but we do want to avoid any hindrances we can. So when you diagnose these things earlier, potentially through the collaboration of someone else may know more than you do about a specific symptom or a specific kind of patient, you can get the patient better outcomes. And in the long run, it can be really helpful for preserving their brain as much as we can. And I think that this is a really good example of when a therapist or a prescriber has a lot of experience with one specific patient population, like Karen in this example, has been a therapist much longer than I've been a prescriber. But if this example were real, she's seen so many patients that after a while, you start to get a feel for, oh, this person reminds me of this other patient I had, and this is the condition they had. So let me consider that for this patient that's in front of me now. And with that lived experience and that clinical experience, you do get quicker, sharper, faster with uncovering those diagnoses. So it's a good example because it shows that we can catch things earlier on, but we can also play to strengths in terms of the education that we have, but also the clinical experience that we've gathered over time. And we can really work together to share the wealth of that clinical experience for the benefit of the patient.
Yeah, just to piggyback on that, Maureen, I know you and I were talking about this yesterday, is that, as therapists, we do know a lot about medications. We've seen a lot of clients on medications and so forth. It is really important that we don't suggest medications to clients. But if we have experience with a client with similar symptoms and we want to say to the prescriber, hey, what do you think about Wellbutrin for that? I had a client that had similar symptoms. What do you think? But keep that as a conversation between you and the prescriber, not you and the client. It makes it very awkward when they go into their next med visit.
I really appreciate that. Wellbutrin is a great example because Wellbutrin is something that we don't use in people with history of eating disorders, and it can also lower the seizure threshold. So if you have any history of seizure disorder, or also people who are at risk for acute alcohol withdrawal or benzo withdrawal, things like that, we wouldn't reach for Wellbutrin. So yes, it could have worked really well for someone else, but maybe this patient also has a history of seizures. And so then I would say, oh no, I'm not going to use Wellbutrin. And then it's tough for the patient because then they say, well, I've been with Karen for years and Karen's always led me in the right direction. Karen's always been a great therapist. She's always helped me so much. And she recommended this thing. And I just started seeing Maureen 6 months ago. And now she's saying, I shouldn't take this thing. I don't really know who to believe. And that can leave people in just a really tough situation.
So I think it's also really important to remember that, when medications are being changed, it's also important to collaborate and to coordinate. So if Maureen was, changing a medication, I'd want her to inform the therapist, hey, look out for any symptoms, any changes in behavior. I did once have a client who was on injectable antipsychotic medication, did amazingly well, but did have a side effect, an ongoing side effect that she didn't share with her prescriber because it wasn't a big deal to her. She eventually, allowed me to speak with the prescriber, let her know about the side effects. She then went in. The ultimate decision was to change the medication. So in the changing of the medication, her hallucinations, her intrusive thoughts all exacerbated. So we did reach out again to the prescriber, let her know what I was noticing in session, what the client was saying in our therapy sessions. We reached out to an outside specialist regarding the symptom, the side effects. And ultimately the decision after looping the client in was to have them continue on the original medication and just keep an eye on the side effect as it hopefully, given the specialist, given the monitoring therapy, and given the prescriber monitoring, would not be a lifelong detriment, but that the risk definitely did not outweigh the reward for the medication. So coordination is definitely, and collaboration definitely needs to occur for a number of reasons. All right, so given the collaboration, it needs to be ongoing. If collaboration has been occurring throughout a client's treatment, then when and if a crisis should arise, it will be much more easily managed and probably more effectively and efficiently. The degree of acuity of the crisis may also be less due to having ongoing collaboration and possibly identifying symptoms and changes in behavior early on. Despite best efforts, we cannot always prevent a crisis for clients, but we can work together to support the client and one another in the event. It is important to note that as a provider and as a part of a team, you are never alone in dealing with a crisis. Please reach out to collaborating team members, supervisors, your site leadership when any of these situations arise. Crises can be scary, and it's important to know that you are not alone to manage it.
So in conclusion, we all have the same goal, right? We want our patients to get better, and we want to see them live the happiest and most successful lives that they can. And also remembering that we are stronger together than if we were to work independently, and if we were to work in silos. We have different strengths, we have different training, we have different clinical experiences and lived experiences, and combining those, we can really give our patient the best care possible. And that plays into the last point as well, utilizing everybody's strengths for the best potential outcomes. I can do some pretty decent motivational interviewing and supportive therapy, and that's about as far as it goes. But Karen knows a lot more, and can do a lot more. And that's the whole thing, is that, yeah, I know a lot about medications, but I'm not great for psychotherapy. I'm all right. But that's okay, because on our team, we have people that are great at psychotherapy. And so we really want to play to everybody's strengths with that. And then last, we've just got some of our sources here. And then other than that, we thank you all for being here. We have some time for questions. I want to start by sharing some questions that we got on Tuesday that I think could be helpful for this group. Karen said earlier that our team secure messaging is all HIPAA compliant. Also, if you were to do a video call with another clinician, then that would also be HIPAA compliant. So don't worry about that. And I think I saw somebody's hand raised there.
Linda?
Hi.
Hi.
So what's the mechanism in terms of transformations to help us collaborate when our trainings don't align? I think ADHD is a good example. I've heard from a number of nurse practitioners that the idea is to treat the anxiety and see where that leaves the client. So that's apparently a trend in the training on that end, but that's not the training that I at least myself as a psychotherapist got. That anxiety is secondary to ADHD, and that it's always present in ADHD, and that the experience of a lot of clients I've worked with over the years is that treating the ADHD reduces the anxiety. And then there's also the factor of teasing out diagnostically um, if the ADHD is comorbid with some complex childhood trauma, because that's the direction the research is bringing us into, that it's pretty much, not they haven't quite worked out the cause and effect. So, like, my role is to have a much deeper understanding of the diagnoses and working with all of that. Um, and I feel like that often comes up contrary, where the prescriber is saying we got to treat the anxiety first, and that doesn't match what I was trained. So how do we work through that if it's as basic as this is what I was trained to do, and I need to do what I was trained to do, and this is what you were trained to do, and you need to do what you were trained to do.
Yeah, well, I mean, it's a good point. And I think a couple things. So one, you can give someone the skills to work on ADHD, any symptoms they're having. You can give someone skills for anxiety. You can do that while I'm treating with medications for anxiety first. Also recognizing that sometimes symptoms of anxiety overlap with symptoms of ADHD, which is another reason we usually treat that first. If you put somebody on Adderall, their anxiety will almost certainly get worse. So you really want to treat.
No, that's not the experience. This is not the time or place for that. But that's not the experience people with ADHD have. Is the stimulant is paradoxical. They go on the stimulant and their anxiety drops. That's what I've heard a million times from people. So like I said, your training taught you one thing, my training taught me another thing. So how do we get past that to provide the
Yeah,
best client care?
Yeah, so it sounds like we've had different clinical experiences, which is fine. But I would say that because if I'm treating anxiety with medication before I'm treating ADHD with medication, that doesn't mean that you can't treat the ADHD first in your sessions. Like those two things aren't in contradiction.
Okay. Yeah. I mean, I'm going to give skills for managing anxiety regardless of where the anxiety manifests from, but it it's there's something very different happening in the brain if it is truly ADHD than if it is an anxiety disorder. But okay. All right. So there's nothing in place to help us work that out. That's what I was asking. So we're just gonna have to agree to disagree and let the client decide for
So I think
themselves.
really the whole spirit of collaboration is exactly what you're talking about, and that is the mechanism. So if Maureen is treating a medication, treating the symptom that she's addressing, and you're noticing things, different behaviors with the client, or they're not really absorbing any of the techniques or the exploration of root causes with you, then that's a coordinating conversation that you have with Maureen. So we're not going to, just like Maureen would tell us what to do in therapy, we're not going to tell her which to address necessarily first prescribing. But we 100% are going to talk to each other about what we're seeing in the client. So I think that is the mechanism, is the collaboration and consultation.
Okay. Thank you.
Yep. Bart?
So I'm the child psychiatrist in the Hyannis office. I would like to respond to the previous question. I think we could generalize the question and say, how do we negotiate if two different providers, whether they're medical or psychotherapeutic, disagree about the diagnosis? If there's a disagreement about the basic conceptualization of the case, the formulation of the case. My experience is that for psychotherapy, diagnosis is much less important than it is for medication management. And we do diagnosis for billing purposes, of course, but psychotherapy is often not specific to diagnosis the way that medication is. And interestingly, I think in psychiatry, particularly child psychiatry, a lot of times diagnosis is pretty murky. And so there can be basic disagreements about how we conceptualize something. We are doing a 1 hour meeting every Tuesday at noon, where I meet with child therapist providers in the clinic and in our region. And that has been extremely useful for us to discuss problematic cases and to come to a consensus about diagnosis and treatment plan. So if the clinic can provide more venues for that kind of conversation, I think that's extremely useful.
Nice to hear that you guys are having those conversations and that you're working with the child therapist as well. I really like to hear that. And I agree with you about the diagnoses being murky and that they are important for the medications that we choose.
And I agree with you and thank you on that as well. And I got about 10 years, I was privileged enough in my career to get supervision directly from a psychiatrist. And what he taught me was that the only purpose of diagnosis is to inform treatment. So I take my diagnoses very serious because I want to make sure that I am treating the right thing for people and getting them on their way. But I appreciate all of that. So thank you.
Tamara?
Okay, good afternoon. First off, I'd like to say definitely appreciate this training because actually this year, this month to be exact, is when I started to have some concerns regarding the information that I was documenting by clients and what I noticed to be different from prescribers. I just have one question. When working with external providers, I know it's pretty much obvious that we are required to have a release form in order to communicate with them. But for the internal prescribers with TCN, do we also have to have an ROI signed by the clients to communicate with them? I mean, we already could see the notes and things like that, but I was just curious to know, do we have to have a release form for the internal prescribers in order to communicate with them regarding our clients?
No, within TCM, we can coordinate treatment with treatment
Okay.
providers.
Okay, that's what. Thank you.
Mm-hmm. Christine?
Hi, good afternoon. I'm an intern at the Brockton location. I had a question. I'm aware that there's a test that folks can undergo to see which medications they metabolize. I guess I'm wondering how often Northeast writes referrals for that test, if and what you think of the utility of said test in terms of prescribing the right medications for our clients.
I mean, in terms of the utility, it's very helpful. We're talking about gene site testing.
Yes, that's it. Thank you.
There's another one called Genomind. It's not as easy to interpret, but gene site is what we use in the DMV almost always. It's very helpful. It's not always necessary to do it. I don't at least do it for every intake, but if I've tried one or two medications, and that's usually when I'll do it, it costs money. So I don't just do it automatically, but at least in this region, they reimburse it up to $300. So like the max you'd have to pay out of pocket is $300. For some people that's doable, for some people it's not. And sometimes insurance covers all of it, but it is really helpful. It's not the end all be all, but it is really helpful.
Okay, thank you for that.
Art?
So I have a request, even a plea. I do read therapist notes when I'm aware that the patient is seeing a therapist. And some of the notes are really informative, and a lot of them are not. What I'm hearing from therapists is that they've been trained to not give very much information in their progress notes. And I think that's for liability purposes. Even medical records, even as careful as we are about HIPAA, medical records are fairly public. They can be requested by various people, and that can reveal information that's being discussed in a therapy session that we would not want to be revealed. It might be actually harmful to the client if their conversation is made public. But I hope that we can find some middle ground where particularly symptoms that are being addressed or not being successfully addressed can be included in therapist notes so that I would be aware of them. My experience is that a lot of times people will come in and not tell me as much as they told the therapist. And then later I'll talk with the therapist and they'll say, well, did they tell you this? And I say, well, no, they didn't tell me that. So it would be great, rather than just having the therapist email me or send me a secure message or whatever, if they would just put it in their notes. I do read them, and that would be extremely helpful.
I definitely think there's a way to do that without providing too much detail. But 100% I understand what you mean. Casey?
Hi, everyone. Karen, I know you have answered this for me individually in the past, but I was hoping that you could provide the insight again. if a prescriber, so say as a therapist, we have our intake, we do our measures, we have our diagnosis, we get our treatment plan done, and then a prescriber adds a diagnosis, irregardless of whether we agree with it or not. Do we need to do anything on our end to update our treatment plans or anything like that? Because now there's an added diagnosis. I was under the impression that like every diagnosis needed a goal attached to it for the treatment plan. So I was hoping you could just clarify that logistically.
So right now in the mass market, yes, because the only formal treatment plan is by the therapist. But again, adding and taking away diagnoses really should be cooperative and collaborative. And they need to make sense. 100% they need to make sense. You can't have major depression and somebody diagnosed bipolar at the same time on the same treatment. It doesn't make sense. So yes, technically, that will probably be changing shortly. So I wouldn't get too caught up in it. I get more caught up in if we're adding diagnoses to a patient chart and not communicating, that would be a larger issue.
Yeah, I think that's how I've run into it in the past, like whether it's something that we've disagreed on or not, like someone added that someone had an opiate use disorder, but the person had been in recovery for like 10 years. So, like I wouldn't have put that, but they put that they had an addiction as a diagnosis. And maybe they needed to because they're prescribing meds and that's important like information to remember. But then I recently had someone who the prescriber added binge eating disorder because they wanted to start prescribing them Vyvanse as a way to try to curb the eating. But me and the client had never spoken about disordered eating. Like it was totally out of nowhere that like that wasn't even in our clinical formulation at all. So it was really interesting to try to figure out, okay, how do I now incorporate this into treatment? And it sounds like the prescribers are having that happen to them way more often than we are as therapists. We usually get way more information, but it goes both ways.
Well, again, if you're collaborating, coordinating with the prescriber, then hopefully you will be able to share that information too. It sounds like if it's to the degree that the prescriber wants to prescribe a medication to curb the eating, then your client's probably not sharing with you the same information. And again, there's different motives for clients to share different information too. They could be looking for Vyvanse. I don't know. There's definitely different reasons why they share different information, but collaboration is the key.
Yeah, and I agree. I would hope the provider would collaborate with you in that instance. I will say Vyvanse is a really expensive medication and insurance isn't going to pay for it unless the diagnosis is in the chart. Whether or not that means it's the right diagnosis is a separate conversation, but I do know that most people can't pay out of pocket for it, so they would need the diagnosis in the chart.
I just want to address one of the questions that I'm seeing in the chat regarding the lack of need for release information to coordinate with a prescriber in the clinic in the markets. In the release packet that they sign, it does say that we can coordinate and supervise. Their case may be discussed within the clinic for those purposes. So that is in the client release that they sign. And it's not necessarily the TCN umbrella, it's your market umbrella. So I'm not going to talk to somebody in the DMV about something that happened in Pennsylvania or Washington or Mass. It really is within your market. Any other questions? Art?
So sorry to be so monopolizing of your time.
We appreciate it.
I asked Brian Whalen at the Christmas party whether we could figure out a way for Valent to let us know that we are each involved in a person's case. When I open up my Valent, I cannot see that there are therapists involved unless I go to open the patient's chart window, which is sort of sideways from what I normally do. So is there any impetus in the organization to get Valent to change that model?
So there's going to be a lot of changes that happen with the navigation of charts with Valent, but for right now, we do use care teams. So for any of your clients, if you go to the Persons and Institutions Patients tab, you can see anybody who's on the care team of that client. So that was where they list any interventional providers, any psychiatrists or medication prescribers, any clinicians, any family therapists, any of those are all listed under that care teams tab. Some of the changes will end up being a lot more streamlined. Right now, there's so many different ways to be able to find information in the chart. So it'll be much more streamlined. All right, if there's nothing else, make sure that you sign in for attendance. I think Jack put the link in. You know, I might have to go all the way up to the beginning of the chat now, but it is in there. So I appreciate your time today. Thank you all for attending, and have a great day.
Thank you. Bye, Karen.